so much, Chitra. And on this Guru Purnima Day, my pranams to every one of you. You have been wonderful. Now, this is basically a teaching a video for someone who's in the early stage of his FACO. And what mishap you're going to see now is something many of us at some or other stage get, especially when we are in the beginning stage. Now just watch it and you will notice that there are so many flaws that are accumulated in that very small movement. And naturally, now this is done by a resident and I was mentoring him and I just happened to be on the microscope. Now this is a time for us to freeze and think. Now, if the resident knows before the surgery what all are the complications that can occur, and if he knows the steps, he's in a much better position. And as you can have to watch again, because not very often, but having looked at it, now you know that that is what you would definitely expect. Because here the phaco tip is not properly occluded by the nuclear fragment. Your two instruments are not working together. Probably the surgeon's understanding of phaco-dynamics is still not that good. His hand-foot coordination yet to improve, and foot switch control is still to get fine-tuning. Now, what is it that you do? As a surgeon, you would freeze here. You would get your second instrument out and get your viscoelastic in. Obviously, the viscoelastic is a dispersive viscoelastic. And once you have done that, the moment your cannula goes in, your irrigation stops and it tries to block that particular defect in the posterior capsule. Now it's time to assess. Now there are certain things which are in favor of the surgeon. We are almost at the end of the phaco and there's only one quadrant left. And the rupture is a small punched out defect with minimal vitreous disturbance. Now, both these things tell you that with good viscoelastic blocking the vitreous, you can always take care of a lot of loose cortex which is still there. Very often I have felt that if you rush in with your cutter, sometimes there's a possibility that some of the cortex can get dropped in. Now, having made sure that most of it is out, the next important thing is to assess how much of vitreous is in the AC. And with a high cut rate, you would go and with very low vacuum, just go near the opening. And the good part is the opening is well circumscribed. And once you have made sure that there's not much of vitreous and the opening is clear, you push in some more viscoelastic after aspirating a little bit of cortex which is there. And then it's a time to assess how do I go about. Now there are two ways to go about. One could just use dispersive viscoelastic, block that opening, go with the phaco with renewed phaco parameters and take care of that fragment. Or one can use the scaffold technique. In the past, we would do sheets glide method, but today you can use a lens. Here, I prefer to use a single piece lens. And the lens is first put into the sulcus. And the nuclear fragment is brought into the center. And you just go about as normal with your usual parameters because you always have a lens there to protect it. And by the time your nucleus is taken care, the pupil has come down. And since the PCC, which is naturally that has happened, would let you use your lens in the bag, it's time to inject epitrate or some way to open up your pupil because obviously you want that single piece in the bag. Somehow you manage to get one haptic in, but the pupil, it will be difficult with a poor visibility to get your second haptic in. So what naturally you do is use your hooks in one quadrant to open up and get some better visibility and get your second haptic in. And all this I could do because, as luck should have it, the opening was small, circular, and well subscribed. Now, one thing we have to remember, when a resident, hands over the case to a mentor and is a part of this completion of a case, he has learned it immensely. So next time, if he gets into this problem or another problem, he'll be able to do it. So this is a small thing that I thought I would share with young surgeons who are in the early stage of patient. Thank you so much.